So now we're in the operating room. We've brought the SPY into the operating room. The machine's been plugged into the wall and turned on. And once it boots itself up, this is the screen that you're going to see. Username is clinical, and that auto-populates. And then you're going to type in SPY for the password. And then type in just log in. This is the screen that you're going to see. You can see this is all information of patients that have had previous SPY studies. And we can review that if we want to go back and look at a patient's sort of historical SPY. But in this case, we're going to do a SPY right now on a patient. And so we are going to open up a new study. New study is going to have a bunch of information that needs to be populated, which includes the patient's name, clinic number, birth date, that sort of thing. And because I'm not the keenest typer, I'm going to have Belinda fill in that information for us. So as she is filling that in, I'm going to give a couple of the key points that we needed to really get in there, so that if you want to go back and look for a SPY image that you need to have in, certainly the patient's first and last name, their date of birth, the Mayo Clinic number, as well as the primary surgeon that obtained the image. Those bits of information are then searchable on the machine, so that you can go back and say, show me all the SPY images that Jacobson did, or show me all the SPY images that were obtained by a certain patient. All of that is then cataloged into that information, and it's all retrievable. So as soon as we've put that information into the patient, hit accept, you can see that now on the screen it says this patient's name and clinic number, and the screen itself is dark. Essentially what this is the black and white camera is on. So I'm going to twist off to the other side here for just a second. So once we've entered in that information, it pops up into the live camera. Now the laser's not on at this point, but the black and white infrared camera is, okay? So you can see just from the ambient light, again, my hand in the screen. To turn on the laser, or to activate the machine to do a SPY study, how we do that is through this handheld remote, or through this port. There's this orange button here, and then pressing that once is going to activate the laser, and it's going to flash orange, and on the screen you're going to see buffering. What that means is the laser's turned on and you're gathering information. You can see it, but you're not recording it at this point. To go from the buffering screen to live recording, you're going to hit this orange button a second time, and then all of a sudden that'll activate the recording process. Interestingly, it goes back and starts recording just a little bit before you've actually hit that button, so there's no delay. So as soon as you see white, you hit that button, it'll start recording about 3 seconds before you've actually hit the button. It's kind of a nice retroactive thing. When you're done with your SPY study, you hit that button again, and it turns off the laser. It will automatically stop recording at 130 seconds if you don't do anything. That then is saved as a file on the machine. Okay? Couple other buttons here to activate. This top button is a laser crosshairs. Now this is not the laser itself, but this is just measuring focal length, and so that you have a standard length of which you're taking the image from, because how far you are away from the target is going to matter how bright you see the images. So that you have a standard image, you just bring those crosshair lasers into one beam, and then you know that at the measurement of whatever you're trying to measure, whether it be skin, muscle, an organ, small bowel, colon, whatever it is, you know that you're at a standard length, so that over time you're able to gain meaningful information from the numbers that you're obtaining, okay? So that's one image. And then the second little icon there, the second button down, it's a camera. And you can use this to just take a still photography. If you want to capture a still photography image and then use that later, you can dump that in a regular JPEG format. Anyhow, it's probably easiest, and in my opinion, you get much better quality photos here at the clinic if you call our surgical photographers. Okay, so that's the buttons you need to know about. We're going to go and look at some stuff on the screen now and images that we've already obtained and use the SPY and the SpyQ software to do some analysis of what we've already obtained as far as images. A little bit later, we'll shoot a SPY image on this patient here. So we're going to review an image that we took the other day. And clinically, what we were doing is we were doing bilateral abdominal flaps for breast reconstruction. What you see here is a picture, just a regular standard picture of the right-sided abdominal flap. This is midline, and here's where the umbilicus was. It's hard to see on this picture, but you see that she's had a scar right here, and that's from a previous appendectomy. So the question in this case was, how does that previous scar, that appendectomy scar, play a role in the perfusion of this flap as we're going to use it for breast reconstruction? So I can bring in the information. I'm going to tap on the SPY images that we obtained, and we're going to take a look at what that looked like in real time. So, to review an image that you've already obtained, there's a couple of buttons that is going to be helpful for you. You're going to tap Viewing and put this into about the middle position. Still going to give us a black and white image, and then what we're going to do is hit play. And we're going to watch this in real time. We're not going to go fast forward. You can see that with every pulse of the heart, I'm just going to pause it right there. With every beat of the heart, just like in that picture that we saw, the flap is here, midline is here, the former belly button is there. With every pulse of the heart, that dye is perfusing through the cutaneous circulation in that abdominal flap. We can look at the left abdominal flap. We can see great perfusion in this area. And now we're looking at the right abdominal flap. Excellent perfusion here. We can see that scar coming across in the mid portion of the flap, and you can see the corners of the flap out laterally. The perfusion or the brightness of the white isn't as good. I'm going to hit pause right there for a second. So what we can do, again, to get the sense of this, I'm going to add a little bit of a brightness to the screen. This part of the flap perfusing well, this part of the flap perfusing poorly. If we want to look at a color image, we can add in the color scale if you'd prefer to look at it in a color image. We can also, again, use some of the software that this machine has, and I can set the contour to help me outline some of the areas that are perfused poorly. And so now this has drawn a green line around, and outside of the green line are things below the level of contour 15. Now that 15, as we talked about previously, is an absolute number. How absolutely bright are we seeing that dye? The other option is to use a relative value where we can touch 100%. We can move this 100% to an area that's perfused normally. And they say, this is 100% perfusion. Show me areas that are 30% or below. So it'll outline areas that this is below 30%. Some of the work that's been done shows areas that are perfused, skin anyhow, that's perfused less than 20% is going to struggle post-operatively. Now, I can tap numbers around the screen, and it'll tell me what are those what are these relative values? Relative to this area, which is 100%, how well is this area perfused, that area perfused, and so on. If the relative values are confusing for you, you can just say, give me the absolute numbers. I just want to know how bright it is. And you can tap the screen, and that's a 37 on a scale, again, we talked about, from 0 to 254. Let's play this image forward. And I take the contour numbers off. And again, now we're looking at this flap, deciding how much of it are we going to keep, how much of it are we going to discard. You can see me taking an ink pen, and I'm marking that lateral corner saying, you know what, that area isn't well perfused. We're going to remove that. We're going to discard that because later on, that's just not going to help us. We can look at the fat there. It's black. It's not going to perfuse well. It's going to have fat necrosis. It's going to go on to have an issue. with regards to this other areas of the flap, you can see it's perfectly white. It's going to be well perfused. It's going to make a nice soft breast reconstruction. No issues of fat necrosis. Again, we're looking at the bottom side of the flap, the fat itself. If we turn our attention to the other side, we see this corner here just isn't quite as well perfused. We flip it over, the fat is black in that corner and the fat is white there. We want to keep the white, well perfused fat for the flap, and we're going to excise the areas that are black or poorly perfused. And again, the edges superiorly, all well perfused fat. And the bottom of the flap the same. Interestingly, again, I'm going to take a pause right there. You can see that appendectomy scar coming right across there. And the way we raised this flap and with the blood vessels that we preserved, we were able to perfuse both skin and fat above that scar, as well as below that scar and lateral to that scar. And we were able to do that safely, but then we could measure intraoperatively how good is the blood flow, how much of this flap can we take. And while that scar played a part of the operation and decision making, we can be absolutely certain when we transfer that flap that it's not going to have an issue with regards to flow, blood flow around that scar. And again, for completeness sake, this is me now taking the black pen and just marking on the skin where that appendectomy scar was. So now we've taken that flap from the abdominal area and we've put it into the chest, and we've put together the deep infraepigastric artery into the internal mammary artery and veins in this patient in each side. After that's all done, we've inset the flaps, and we're going to make sure that what we have is perfusing. So we're going to do another SPY image. Again, this is after all of the inside of the flap and the microsurgery has been done. You can see normal chest skin. You can see a couple of areas of darkness initially where there's some stress from the old mastectomy flaps. But you can see this SPY image shows that that flap has got arterial inflow. And you can see the cutaneous perforators in the flap itself. And you can see that the medial portion of this flap is perfused very well. Sometimes you get in this corner of you can see the mastectomy scars here and the mastectomy skin here. Nipple-areolar complex perfusion very well. Again, from previous nipple-sparing mastectomy and flap surgery. Occasionally around the corners, like you see in this corner, you get what I call the disco ball effect, okay? And again, along this lateral corner. On curved images, as we talked about before, this dye is shooting a light up towards the camera. So on a curved image, what you will see the best is the very top of a curved image. Around the corner, it's shooting the light out that way. So that's why this handle articulates, right? So this is why you can move the handle this way and that way and this way and that way to make sure that you're seeing the absolute perpendicular surface so that you can measure what you're looking at. So I would say that this area around the corner, it's giving me a falsely dark result because that light's being shot off to the side, not up towards the camera that's being received there. So on this image, this is a patient that's had a mastectomy, nipple sparing on the right side, and on the left side, the nipple-areolar complex had to be removed. As you can see, the nipple itself is a little delayed, but you can see the blood vessels going to the nipple-areolar complex are present. And then with just a little bit of time, we're into about a minute into the study, you can see the white perfusion of the nipple. So I know with great confidence, we're not even going to have a scab at the tip of the nipple post-operatively. She's going to do very, very, very well. On the other side, a little bit different story because, again, like I said, because the cancer required, we were planning on nipple-sparing mastectomy, the nipple had to be removed as part of the oncologic treatment. That left us with an incision in the bottom of the breast from the nipple-sparing mastectomy, as well as an incision in the mid portion of the breast where the nipple-areolar complex was removed. In that intervening area, You can see the comparison of the tissue here versus the tissue here. This does not look as well perfused. The question is now what do we do with this information? Because I have an adjustable implant, and you can get the sense that there's some contour there, I'm going to make an intervention. I'm going to say, you know what? This is not ideally perfused. I'm going to take volume off. I'm going to take all the stress off of the skin, because when I put my contour numbers up, and I'm going to outline areas that are under that threshold level of 15, and in this area here, it's outlining those areas that are under those levels of 15, and it's saying, hey, Dr. Jacobson, pay attention to this. If you ignore me, I'm going to give you trouble, just like we saw about in that video as we talked preoperatively. So no intervention, no translation of this information into my practice, it's going to give you a problem. But we're going to make an intervention. So now what we've done, we've made an intervention, we've deflated the device, so we've taken all of the stress off of the skin envelope, and we're going to see that it's going to make a difference in the perfusion overall. I can skip ahead to here. Now I put my contour numbers up. Now it's flat. You get the sense that it's a flatter surface. I don't have any stress on the perfusion. We talked about the resection continuum and the reconstruction continuum, its impact on perfusion. I've taken the reconstructive stresses off of it, and again, on that absolute number, that contour 15, it's showing me some false positives out around the corner from the disco ball effect that we talked about earlier. And we look at the area here and say, that looks much better. In fact, if I turn up the brightness for you, you get the sense that this perfusion is improved because we've made an intervention. We've taken the stress off. If we wanted to look at it in a relative value and bring up an area that say, this is relatively 100% perfused relative to the other areas, and show me areas, again, that other surgeon that I was telling you about, Marty Newman down at Cleveland Clinic in Florida, he's come up with a number of mastectomy flaps that have less than 20% relative perfusion, are going to have troubles. Here's where we're now looking at relative numbers, 100% perfusion here, and I've asked the machine to outline the areas that are less than 20%, and you can see I have none of the areas on my reconstructed breast that are less than 20%. I know I'm going to be able to leave the operating room confident that I'm not going to have perfusion issues with this patient.